Thank you so much. Welcome. I hope everyone feels more engaged since they were able to get up and walk about a bit. So this morning, we will be presenting on how JCPenney improved the health and productivity during the recession. And I am Teresa Bartlett. I'm the medical director at Sedgwick. Really happy to be here today. I have a background in managing workers' comp, disability, wellness, healthcare programs from the employer side. And now with Sedgwick, I am honored to be the medical director and have a lot of responsibility for clinical operations and integrated programs as well. Presenting with me today is Matt Harmon, who is the benefits director and retirement director at JCPenney, and we are honored to have him today. He was named the benefits manager of the year by Business Insurance last year, and I don't know, am I getting feedback here? No? Okay. And Matt has been with JCPenney for the last 5 years. He was named in 2009 the Chairman's Award for JCPenney. He has made such a profound impact on that organization, and I'm really excited for you to hear this story today and to understand how this whole program came about. So from an objective perspective, what we'll do is we will share with you sort of the backdrop of how JCPenney started, and then define the exact problem. Actually, Matt will do all that. Then we'll talk about the healthcare and wellness and disease management and how all those programs integrate into the solution. We'll discuss the different initiatives. We'll talk about benefit integration as well as integrated disability management. And then the results and how, from a success factor, how was Matt able to really build this story and what's next? So with that, I'll turn it over to Matt, who will begin the presentation.
Thank you, Dr. Bartlett. Thank you for having me this morning. I hope everybody's awake and alert, having walked around a little bit. I'm going to try and keep this informative and entertaining so that we continue that progress. I want to give you a little bit of a backdrop about JCPenney. When I joined the team, what was going on? We call it the perfect storm. So back in 2008, we all know that there was a recessionary time frame for retailers. That's a pretty difficult time economically. We also had some pretty significant challenges organizationally. I'm going to take you through those challenges. If you've seen us in the media over the last 3 years, the just huge amount of organizational transformation and retransformation that we've had. So I'm going to cover what those kind of continuous issues have been, but also some of the things that have stayed the same kind of on the health front. We also had a business problem. So some folks think of health as a problem or a lack of health as a problem. We really saw it as an employer as a business issue. We were faced with double-digit healthcare increases, as were other employers in the country. We were faced with the very salient point of, if we did not do something, our healthcare trend was going to double our spend over a 5-year period. That was going to start to hit earnings per share and create the inability to have a sustainable program for our associates. So we absolutely had to take action. We had a couple other uphill challenges that I want to talk about. Number one, we had an aging workforce, probably a good 14 years older than the retail average. We also faced some uphill claims issues with 33% higher claims costs than average retail. So as we're beginning this journey at the bottom of the hill, not only do we have this business issue to solve, but we have some parameters that don't really have us off on equal footing. So I want to kind of talk a little bit about that, but also help you all understand some of the things that were at risk. So we have employee productivity. We talked about that in the earlier session. Hugely important for a retailer who has people in stores across the country. And we also have compliance risk, right? With the advent of the ADA and ADAAA and how some of that interactive process has become more and more important, we needed to make sure that we were fully compliant and consistent with those programs as well. Okay, so to kind of kick us off and start to create some order of magnitude, I want to share with you just how many shirts would JCPenney need to sell to support just our full-time medical program. So here you see 140 million shirts. Maybe it's a little higher, maybe it's a little lower, depends on the kind of shirt, but either way you look at it, it's a shirt load, okay? It's an absolute shirt load. So 140 million shirts just for full-time medical. That doesn't get into workers' compensation, non-occupational. There is a variety of costs, but this is kind of setting the stage for order of magnitude. Okay, so the first step to really attacking a problem is defining it. If you're not clear on what the problem is, you certainly can't create the best solutions. So let's really talk about what our problem was. Healthcare costs were rising at double digits. Many other employers face the same problem. Our trend was going to double in 5 years and make healthcare unsustainable as an offering to our employees. Okay, another big problem. What were we offering in terms of our plans? We had some PPOs that had the illusion of a $10 cost of service. I think we've all kind of learned ourselves into thinking $10 is the overall cost. It's not. We all know underneath the covers the cost is much, much more than that for an office visit. We also had some very low utilization of a consumer-driven plan that we had one of, okay? So not much consumerism going on. And then finally, everybody kind of knows those who have the most chronic conditions represent 80% or more of the cost in a program, and those who are in that stage were not really engaging in managing their conditions. So obviously we had the perfect storm of problems. What we knew, and probably the best thing for us, was there was no opportunity to do nothing. It simply was not an option. We knew we had to do something, and we had to do something radical. It wasn't tweaking a plan design. It wasn't offering a smaller, additional incremental benefit. It was reinventing healthcare at JCPenney and helping our associates to understand what it meant. So that's the problem, but let's talk about the necessity of invention. So necessity is the mother of invention, and we had to make changes. So what we did, we ripped off the Band-Aid, full replacement consumer-driven plans, 2 different options, okay? Preventive care covered at 100%. That was talked about in the earlier session. How do you kind of get that out to everybody? We adopted that much before the ACA required it. We had a lot of education necessary, and to do that, we'd had passive benefits enrollments. We moved to active enrollments to make sure every year our employees were thinking about it, they were taking action, they were becoming engaged, and one of the things that was really clear is we had to have a very high-touch rollout, an extensive amount of communication and dialogue with our associates for all of these complex concepts that most of Americans struggle to wrap their minds around. We now have to get them to understand it, take action on it, change their behavior, and get on a different path than they had been in the past. So one of the things that we had implemented along with that is a personal health assessment. You certainly can't impact your health if you don't know what your health is. The way we took a slightly different take about it was, in order to get people's attention, and it's very clear that we needed to get their attention, we introduced the personal health assessment as something that, in order to avoid a $600 a year surcharge, no incentive, we had incentive, we moved to disincentive, to say, how do you get people's attention to get to know their numbers? So the first stage of that was, you need to take a PHA annually so that you know your numbers. The second piece was, if you're identified for a lifestyle meaning smoking or weight management, or a disease management program, and that's all of the 5 top disease states that everybody's familiar with: COPD, CHF, diabetes, hypertension. I bet you could look at the employers in the room, and your demographics, if you looked at your 5 top cost drivers, probably wouldn't be terribly different. So we looked at those groups and said, those are the groups that we have to reach. Okay, so what did this kind of huge wholesale shift lead to? Well, we knew that we had to create some awareness first, we had to create some education, and then we had to be able to get people to engage. That is a multi-step process. Very difficult to do for a population that's used to a PPO, where they go to the doctor, they pay $10, and they're done. Okay? So what we really did is got very transparent very quickly about what things cost. It's not $10, it's actually $150. You're now paying the bill. Do you want to pay $150 at provider A, or do you want to pay $250 at provider B? Well, wait a second. That impacts my wallet? It absolutely does. Okay, now we have a dialogue going here. Now we've got an understanding. Some of the things that we really knew that was important is we had to figure out how to get people's skin in the game. If they weren't in the game for themselves, then it wasn't going to work. We talked earlier about not forcing people to be healthy, not forcing people to engage, but if they don't have some skin in the game, it's certainly not going to happen. We'd all like to think that people would get involved in their health so that they would improve their health, and that would be the end goal. But certainly financials seems to be a lever where people start to understand if I'm managing the cost and it's impacting my bottom line, I'm going to start to take more of an interest. I think that's one of the things that have been proven in our discipline is people react to anything that hits them in the wallet. So what was the impact of this surcharge? We knew we had to change behavior. This wasn't the flavor of the day. This was truly changing behavior. So we had 45% participation in the personal health assessment when it was an incentive program. When we moved it to a surcharge program, we moved to 95% participation. So a huge difference. We also started to see that our employees, and particularly the ones that were in those disease states that were high cost and had the ability to manage their conditions and lower their own personal spend, that they were able to engage in those programs in a lot greater percentage. So what we want to talk about in a little bit more detail are some of those positive results.
But Matt, before you do, I'm just curious, a lot of companies here, I'm sure a lot of employers here have wellness programs or they have personal health risk assessments of some form. So those impressive rates are impressive, right? The participation rates. What was the resulting factor when someone did take a personal health assessment? How did they take it, first of all? Did they take it on paper? Do you have a phone-based? Do you have a web-based? So question number one, how was that? And then secondly, if they had this disease burden that you talked about, your 5 key drivers, what then? How did they get the result and how were they engaged in those programs specifically? Because I think that does vary from program to program.
Yep, so our particular program, they could take the personal health assessment online through the same single sign-on portal that they accessed all of their benefits. We'll talk about in more detail about that later. It's in English and Spanish, so there was, a prevention of a language barrier. You could fill it out on paper. You could call into the contact center. There was many different ways to accomplish that and people there to support you in doing it. And in terms of the result of what they would receive a report back on their own personal health, identifying any areas of risk, whether it be one of those 5 top disease states, whether it's another area that they could personally manage that wasn't subject to a surcharge, but they might want to personally get involved in order to better their own health. And then they really needed to understand that it was something that they could use going forward. It wasn't do it once. It's I need to monitor my progress now, every year, and this needs to be a living, breathing document, so I'm kind of tracking my health. So when we really looked at it and we got with our partners at United Healthcare, we really started to think about how do we outreach to these folks. We know sending them a letter isn't going to do it. We all know how much people read benefits communications and how much time they spend doing it. 0. So how do we really reach these folks and engage them? So we had direct outreach from nurses to reach out to all of these individuals to start that dialogue, to introduce the program, to kind of talk through what are the benefits to them of being engaged in the program, or if they chose not to participate in the program, what the financial penalties could be. So there was a very interactive dialogue from nurses to our associates. Now, we communicated via mail as well. There was a lot of different channels, and we reached to people in any way that they would listen. But probably the most successful was the outreach from nurses, and those nurses really getting it home why that person needed to engage.
Thank you.
So let's talk about, it's great to talk about doing something like this, but as employers, think about how much different it is to operationalize that and then communicate that to your population. It's a vastly different animal. So I'm going to walk you through kind of what we did. So I call it the frozen carrot. If you let it thaw out, it could be an incentive. But what we really wanted to do is to avoid a $600 annual surcharge, you needed to do 2 things. One, you need to take your personal health assessment annually, so you know your numbers. If you don't know your numbers, you can't engage. How many Americans are out there that have diabetes and don't know about it? How many people are out there that don't think they have a problem with their health, but they just don't know. And if they don't have that baseline or that awareness of what their health is, there's nowhere to go from there. So you have to start with a baseline of what is my health condition? And the only way to do that is to be able to take a personal health assessment. So, okay, we got 95% of the people taking it. That's pretty good. That's a good start. Now, the second part is if you were identified for one of these programs, you needed to participate in that program. Not that you needed to graduate from the program to stop smoking, but you needed to engage in the program to at least make an attempt to do it. So that's all that we asked of our team. We didn't force them to do anything. We just created the opportunity. So we got great increase in terms of take rates, but does that change behavior? Does that get results? So let's talk about what kind of happened with the results themselves, because I think that's really where the rubber hits the road.
And
Dr.
I can
Bartlett?
just jump in here. First of all, these are fantastic results. You can see them on the screen. But you should know, and I'm sure many of you do, that smoking is the #1 preventable cause of death in the United States. And it's estimated that it actually drives $193 billion in cost. So if you look at the American Cancer Society's website, they have a cost calculator, and they estimated that a pack of cigarettes to an individual costs $35, and to an employer costs $65. So if you look at that 3% reduction in tobacco use that JCPenney achieved, those are huge dollars, real dollars. So that's, congratulations, that's a big win. And in terms of obesity, we do know that $164 billion in lost productivity is associated with obesity each year. And the Robert Wood Johnson program suggests that that will grow by 2030 to $580 billion. Huge burden on the economy. And the other problems associated with obesity are things like increased mortality rates. Those folks pay a lot more for prescriptions, 105% of those individuals that are not obese. So there are some great things to think about in terms of these wellness and disease management programs that can actually incentivize an individual to participate when they start thinking about things in terms of their health and their financials.
Yeah, and we actually did a lot of kind of communications that were lending themselves to exposing that true actual cost so people had an awareness of what it was actually costing them. You'll notice on the BMI, obesity, I think, I'll let the good doctor correct me if I'm wrong, but about 35 is really considered obese. We actually went a couple of ticks before that at 33, because not only did we want to get folks who were obese to move down the scale, but we wanted to prevent those who were just on the border of getting there. And I don't have to tell you all about the comorbid conditions that can exist when you're overweight and smoking. There's heart conditions, there's all kinds of things, and it all becomes tied together in your health, and it creates compound risk for an individual. So you have to be able to address it. And we had situations where we had individuals where we had to line up the issues that had to be dealt with and start with the top priority one and work our way down, one kind of condition at a time.
So Matt, when we see the results here on the savings that are associated with the wellness, $6 million in healthcare, $7 million productivity, $2.8 million in workers' comp. Just for those attending today, I'm sure they're interested in how do you go about calculating those savings and reporting it to a board and making it a meaningful number.
Yep. So that's the key, right? If you can't show results, it's pretty hard to get a program off the ground with your board, with anybody in the business, anybody who owns the purse strings. So one of the things that we did was actually sit down with our partners, United Healthcare, Express Scripts, Sedgwick, and really look at where we were in some of these conditions across our population and say, if we were successful in even bending the trend a smidge, what would that result at kind of getting us towards the retail industry averages, and what would that result in costs? So that's what we use kind of for our initial projections. As you know, we had no choice. We had to go down this road. So I guess it was a little easier because we had to take action and everybody knew it. So those are the projections initially, but nothing talks better about what the costs or the savings were than actual hard dollars. So what's on the screen here represents our full-time medical spend, okay? And it's from 2009 to 2013. So the percentage of spend on the left axis really kind of talks about where we started. So back when I told you about our little problem of potentially doubling our spend over 5 years, now we can look and see, well, what was our actual result over kind of nearly a 5-year period? And what you'll see is a 25% aggregate cost reduction in our overall full-time medical spend. So that's not small dollars, that's big dollars, and it's measurable, and it is actually the opposite direction of where we were heading. So now we have the ability to go back and show these results and to be able to say, we took a little bit of a leap of faith based on thinking we could move the needle, but it is absolutely essential to go back and prove out what actually happened. And as you can all imagine, there's all kinds of other factors that can play in. What was happening in the business during that time? You know, in 2012, we experienced some reductions in force. So we had less participants in the plan, and that's why you see a little bit larger spike there. But those reductions were nothing compared to what we were experiencing in cost reduction. So across that period, 25% was significant. And then you might ask, how do you message that to your employees? It doesn't sound very good, right? Hey, we saved a bunch of money on health insurance. How do you think that goes with your average employee? Not well, okay? So what we really needed to help everybody understand was it's kind of a partnership. We're all in this together in a self-insured model. Everybody who is engaging or not engaging is affecting everybody else's premiums, everybody else's cost in the short term and in the long term. So what we were able to do with our employees so they could see these results is we didn't have any increases in premiums over that period of time. So they saw that if they started to become consumers, they would actually be able to change what they had seen as huge increases in their premiums year over year.
So are you saying that you kept their benefit level the same too? Because I know a lot of employers in the marketplace are looking at reducing the contributions from the employer, looking at spending less by taking that out of the employee.
No, we can't do that. Our folks are hourly workers in the stores. How much disposable income do you think they have? Not much. So it's really not an option for us. What we did do is we kept their premiums the same, but we actually reinvested much of those savings into enhancing their benefits so that their benefit was actually getting better while their cost was staying the same on premiums. And then as we were getting people to become better consumers by support tools like shop a procedure, shop a drug, all of those types of things where we provided pretty heavy communications to help them understand where they personally could save a lot of cash with real-world examples. What we did was we made them a little bit better consumers, so they spent the same in terms of premium, and they actually wound up spending less in terms of what they were spending on healthcare because they were better consumers. As an example, we went through things like, if you're to go to this hospital that's here right in the local market and get an MRI, and you're to go to this imaging center that is 2 blocks down the street that has the exact same equipment, the exact same techs, and the exact same net result, and one costs 3 times the amount and gets the same result, and you're paying for it, which one are you guys going to go to? So we provided that kind of example, those kinds of case studies. Diabetics who manage their conditions save themselves and the company 3 times the spend. They could see those dollar savings. Now, you can't always shop something. Sometimes you just have to go. But if you got an MRI and you got weeks before that happens, we haven't questioned the good doctors in the past as consumers. We've just kind of, hey, they know best, we're going to go do it. It helps people to stop down a little bit and think about it. Do I need to do something differently? Do I need to shop for this? People will shop for car insurance. People will shop for a new stereo, and they'll spend hours and consumer reports and all kinds of heavy time out of their day to do it, but arguably the most important thing and one of the biggest costs in their lives outside of housing is healthcare. So that's kind of an inverse problem that had to be solved.
So that's a huge complexity in communication too.
Yep.
So what I heard you saying is you're developing these individual strategies at their level that are real. So for example, if you have diabetes, you can do X or you can do Y.
That's right.
And that was sent to them through all your various channels of communication, or?
That's right.
Okay.
Done through outreach too. I mean, some of these nurse programs where they're having those conversations with individuals who were treating their diabetes by crashing and going to the hospital, probably not the most affordable for them or for the company. So in the past, if they had a $25 copay at the hospital, it wasn't a big deal to them. However, now, if they go to the hospital to treat their diabetes in the emergency room, they're going to be paying a big portion of that bill. So they need to be very aware of it, and they did become aware of it, at least to drive some significant results. But it's a continuing education process. Are all of our people the best consumers in the world? Nope. Are they making some progress? Yep. And how do we know? We can look at the dollars and cents of it. So spending less on healthcare is attractive to anybody to get better quality service, and it's about outcomes too, as you know. You have to make sure that people aren't shopping in a way of they want to buy the lowest cost thing. I think there's a scene in a movie where Steve Buscemi is in Armageddon, is sitting on a nuclear device, and he's getting ready to take off, and he says, "Wait a second, help me understand. I'm sitting on 10,000 pounds of rocket fuel and a rocket that was built by the lowest bidder." Kind of not a great proposition. So people have to also understand it's not just about the best price, it's about the best outcome. So there's another kind of wrinkle in that complexity of being a savvy shopper. You need to understand that. So we had a lot of other initiatives as well that started to evolve, and what we're going to do now is kind of tie those in and then see how it all fits together. So in the earlier session, there was discussion around on-site clinics and pharmacies and what you can do when you have an order of magnitude in a building. Well, we certainly had that at JCPenney in our headquarters in Plano, Texas. So if you build it, they will come. On-site clinic, on-site pharmacy drives employee satisfaction. We saw the results in surveys. Drives convenience, drives productivity from folks not having to get in the car, drive somewhere, and in many cases, we were able to get them a better price on those services, or in the clinic, if they wanted to go for an office visit, we were able to offer that for $10.
So, a lot of employers, again, would probably love to have the pleasure of having an on-site facility to provide the health care. I'm just wondering, how did you do it? How do you build the business case? How do you financially build the whole scenario so that this is successful? And, did you outsource it? Did you build the brick and mortar? How, that becomes very complex and a big challenge for a lot of employers who would love to be able to do this.
It is, and I'll talk about the bigger challenge, which the gentleman from Target was addressing, to say, it's great if you can build something in the home office. How do you get out to 49 states and over 1,100 stores to get wellness in a box out to your population? So we'll talk about that in a minute, but in terms of the on-site clinic, we actually had MCNT, who was in there for years, kind of on their own accord. They saw a number of people, and they said, hey, we think we can offer a great service. That really wasn't working well because it wasn't our clinic. What we were able to do, though, is leverage the fact that the capital investment of having that built and the exam rooms and everything was already there. All we had to do is bring in the right provider and make sure that we had the right business model, seeing the right number of patients to not make money or even necessarily save money, but at least create an environment where employees could engage in these things, and it was at least cost neutral. And there could be some upside if more participation were directed to those facilities. So that's in essence where we landed with the clinic. With the pharmacy, it became another experience thing. If I go to the clinic and I got to get some meds, by the time I walk past the clinic, I can walk into Walgreens and be able to pick up my script, which creates a highly convenient situation for the employee, increased productivity, and finding that we are actually doing a little bit better than break even on the clinic and pharmacy, helps us to continue to offer that. Many folks start one, it doesn't work, the financials aren't there, and it gets shut down.
Right.
So you never want to open something that you can't sustain. So we had a vision of sustaining this. But then the bigger problem, so we were able to say, and we can wrap health and wellness things around it. We launched a health and wellness day. We did walks with executives so we could get some of the physical aspects there. We had a farmer's market. We had all kinds of things because now we had some kind of orb to get people to get around that was right there that they could understand and they could engage in. So that all worked great. The bigger problem is how do you get out to all of those folks in the stores? Store by store has a different kind of culture. They're in a different area. So a little bit like Target, we have champions in each store, but the biggest ways that we started to reach out to our folks were, in short, any way we could. So we have single sign-on functionality from one place with one password to get to all of our service providers, to get to all these tools, whether you're enrolling, managing your cost, ordering a new prescription, all through one site. We have web chat and mobile. If somebody prefers to send a quick message, they don't want to call, they need a quick answer, so we have those applications. But what we learned is there's a desire still to have town halls and to have somewhat face-to-face meetings with employees to discuss these very complex things and allow them to ask questions and check for understanding. So not only do we, anytime we make a change, we have a town hall with every line of business that sits in the home office. We have a call with every group in the field to be able to have that dialogue. We have live broadcasts at least 4 times a year that play in all of our stores and allow those employees to ask us live questions real time. Without that, we wouldn't be able to have any kind of engagement with our folks. So that's how we started to really address some of those decentralization things. Multiple mailboxes for folks to reach out. So, hey, I'm having a problem, I don't understand something. There's always somewhere to turn and an advocate to help. And what we really learned is we have a hotline for benefits. We have a nurse line where folks can call and get direction of care. Hey, I heard I could save money by going to one of these kind of local providers in my neighborhood as opposed to the hospital, but which one should I go to? And is that one covered by the plan? Well, if you contact the nurse line, they'll help you through that process, and they will actually do it for you. If it's too sophisticated for you, all you have to do is call this number, and they will help you through that process. With Express Scripts, we have 24/7 speak to a pharmacist. So I need to know what drug I need, and I need to know if there's a generic, and I need to know some of the things that would help me be a better consumer. 24/7, you can reach a pharmacist. So without those tools and those multiple methods for people to get at using those tools and that education, we wouldn't be going anywhere. So this was actually very, very critical. Okay, so moving into integration. So how does this all kind of come together? We're talking about health. We're talking about now some of our other things that we offer in terms of integrated disability. But people only have so much bandwidth to digest all of the wonderful benefit stuff we all create every day in our lives. So we knew we had to have one single point of entry. So we talked about where do those things go wrong. Sometimes our folks would get very confused as they got into the healthcare system. They would get lost, and one provider would point at the other provider, and before you knew it, the employee was absolutely ticked off. That doesn't help us engage. That actually pushes them away. So what we learned and what we implemented was what we call a Tier 2 call center for individuals who find themselves in that kind of situation where they can call, and whoever picks up the phone on the other side is going to understand and own their issue and work behind the scenes in the healthcare system to really get that employee what they need to move forward. If we didn't have that, we'd have a lot more confused people and a lot less utilization. What we also learned is anytime you're accessing something, if you have 5 passwords, you're not getting there.
Yeah.
One password, it's the same password you have to log in to clock your hours, which is how we pay folks. So they got that one down. So we started them there, start very simple. We also learned that we all like to put all kinds of information in our communications to cover every aspect of something. The bandwidth for our folks is about a 5th grade reading level on average. They're going to spend about 10 seconds looking at anything that we send them if we're lucky. So we have a very short window to engage with them. It has to be simple. We call it duckies and goats, like the Brothers Grimm, the pop-ups and the stories. that's captivating. We know that we have very little time and attention and little sophistication for our employees. If we're going to get them engaged in this stuff, it has to be simple. So we brought all this together in one place, but more importantly, one of the things that we realized as we were going through this is, okay, great, we'd started to work on the health piece of it, which, as we talked about this morning in the prior session, that's one half of it, but this is all a holistic view. For integrated disability management, we found ourselves insourced for non-occupational, and that created a lot of concern. We were outsourced with another provider, but there was no kind of integration of those. There was some things and some pain points we were feeling and some concerns we were getting with legislation becoming more and more prescriptive, that if we don't have a very consistent, compliant program that we can really monitor and keep our arms around, we're going to have some problems downstream. So for that reason, we decided to go out and really find that provider. We started wanting to create an integrated disability management program. Then we wanted to take that in its evolution to more of a productivity management program. And eventually, we'll talk in a few minutes about how we want to eventually arrive at total health and productivity. So number one reason that we were able to make this decision with our management, compliance and consistency. Our legal group backed us up on that one. Usually your legal group is a barrier. In this case, they were an advocate because they know the EEOC and the ADA and all of the things that are coming out there were becoming more prescriptive, that you have to do it. You have to have that dialogue with frontline managers. With 1,100 stores, that's a lot of people. So we needed to make sure that we were high and tight on those areas. Tighter management of some processes where there's potential for leakage. Hey, somebody's out of work, so we're paying them, but maybe they're in an appeal status. So they haven't actually gone on leave. They're kind of waiting to go on leave, but in the interim, we're still paying them. So it creates a productivity loss. So we wanted to address that. We knew that we had some opportunities for savings by bringing it all together. We knew we had some opportunities to make it more of a holistic interaction and look at the individual in their life event as opposed to looking at the transaction one at a time and then on the back end trying to figure out what happened. So as we started to move down this process, we really understood that we needed a provider, a partner who would be with us on day one and evolve with us through the rest of our kind of evolution. Enter Dr. Bartlett. So yeah. What were we trying to address with this integration? Cost is always fun. Can't talk about benefits without cost. Silo environment. People kind of getting siloed and doing their one thing but not knowing what's going on the other side. If you squeeze the balloon on one side and it simply inflates on the other, you really haven't solved the problem, you've just moved it. We knew that we had some leakage. There were some opportunities to really tighten down some of those processes and make sure that payroll was getting feeds very timely to make sure everything was really happening quickly and there was no dollars floating out the door. And then simple lack of communication. If you are an individual who goes out for a work comp issue, but you're also on leave and you have 6 different people talking to you, and then you got some other doctor calling you on line 3, you're going to get confused. You've got to fill out a ton of paperwork. I think Mary mentioned how much it costs to fill out paperwork these days. So I'm this individual. I got 10 people pulling at me. I'm immediately confused. And where does that go? Noise to the employer. So we knew that we had to address that. So as we started to set the stage for what we wanted that holistic view. It's not just an incident. It's that person's life and anything that comes with it, whether it's personal or professional. We wanted to be able to enable our provider, who's our partner, to be as successful as possible by bringing them into our culture, helping them understand who we were and what drives the associates at JCPenney, and to get that kind of true alignment. And then finally, we really wanted to capture all the information, not just data, because we all have tons of information, get analysis paralysis, but what is this data telling us? If we look at it holistically, what is it telling us? And so we knew that we had to take it to a different level.
Right. And so as you know, that there is an evolution to integrated disability management. It doesn't start integrated usually from day one. And JCPenney, being such a great partner with Sedgwick, has enabled us to get to that point of integration. When we started the program, we had workers' comp throughout the entire country. We had all different call centers. We had a program manager for workers' comp and a program manager for disability. We had different measurements of quality and, all different types of training. And what has happened is we've really been able to integrate this whole program into a single platform for JCPenney. So there's a single call center where their associates call. There's 4 major hubs of workers' comp. We all know that there are those jurisdictional opportunities where you have to administer in a certain state, but there are 4 major hubs where we administer that. We have 1 single program manager, Frank, who's here today, and it really pulls it all in under 1 umbrella. And then the quality also, 1 measurement of quality, 1 measurement of training, so that we're absolutely getting the JCPenney specialized training out to our colleagues so that they truly understand what is expected, what the culture is, and how they will deliver the best-in-class benefits for those team members.
Yeah, so why is it important to us, and what is it about this program that we really needed to have to be successful? So there's the alignment. There's 1 throat to choke. Frank, sorry about saying that, but that's exactly what it is. As an employer, you guys have got limited bandwidth, right? You can't go manage 10 different people at one organization. You have to be able to work through 1 person at an organization. If you're lucky, you have time to do that. So you have to have that alignment. Also, behind that in the organization, you have to have an alignment. So there's reporting relationships directly to Frank so that he can manage each of those programs. So those 4 hubs for work comp, all those people are dedicated to the JCPenney program. Not designated, dedicated. Why is that different? It's different because those are our people. That's our staff. We can go in and talk to them about how we expect the program to be administered, what's important to us. They're not focused on other things. They're focused on us. So we're able to set how many claims that they're working on so that they can be successful in working them to our expectation. So that's a partnership, right? You have to be able to say there's pros and cons and costs that goes with that, but how do we maximize this relationship? How do we get the alignment so that those, not only adjusters are dedicated, the supervisors are dedicated? Because if you don't have it all the way from the adjuster all the way up, it doesn't work. However, if you have that alignment, you can get some pretty significant, substantial results, and we're going to kind of talk about some of those that we've already realized. Okay, so think about this first before we get into the details of the results. Refresher, back in 2010, we were fragmented. 2011, we started to build this integrated disability management program. 2012 to 13, we were fine-tuning that program, maximizing each piece. Anybody who thinks that you're going to start and it's going to work perfectly out of the box, you probably need to go into the other room, think for a few minutes, have a cup of coffee, and then come back. Okay? It is an evolution. What works for some doesn't work for all. Providers can say, here's what we've learned. We all know everybody's different. Every employer is different. There's different dynamics. So you start with your best assessment of how it needs to work, and then you have that partnership to fine-tune. As we got into 2013, what we started to realize, the data was telling us things. And how could we use that data through predictive modeling to be able to understand what was going to happen and then create an intervention to stop it from happening if we could, and if not, at least catch it sooner before it became more expensive or more catastrophic. In 2014, as we kind of move ahead, we all know we have the Affordable Care Act. I think it was pretty clear in the prior session how much of an impact that can have on work comp, on non-occupational. So anybody who doesn't have their eye on that is going to be probably very surprised. I don't think any of you, can you say that you could afford to have an increase in costs in that program? Could any of you say that?
I see no hands.
I don't see too many hands. So if there is 3 or 4 things that drive cost in those types of programs, it's incidence, duration, direction of care, and if you lose that, or it doesn't quite translate through the Affordable Care Act and the health system and some of the things that were being discussed earlier, you're going to have an increase in cost. You're going to have people out longer because they can't get to care as fast as they need to, and if they can't get to the doctor that you want them to go to, they're going to go to their doctor, so you lose direction of care. Okay, so all of this data became information and enables us to really make some pretty significant learnings come to light. So,
And I would just like to add here that it enables us and Matt to look at, for the first time, an employee-centric model. You know, we often talk about medically-centric models, but when you can, for the first time, look at an employee and understand that they have FMLA or that they have a leave of absence and a workers' comp and a disability claim, and maybe their child has asthma, and pull all of that information together, it really enables us to be able to get to that prediction that Matt was talking about, and really allows them to level the workforce and look at trends. I think on that next slide, do we have the, oh no, oh yeah, here's the results. So the results are fantastic, obviously.
yeah,
but
so let's talk about the results and reflect back on the prior slide about what we're really getting at. So you got to identify a problem. You got to have targeted solutions for those problems. You need to be able to create overall strategies that address not just the one issue, but the more broad issue. And then as we look at these results, one thing we were concerned about going in is, do you squeeze the balloon or the toothpaste on one end and something shoots out the other? So we felt very compelled to look at short-term disability, long-term disability, workers' comp, and then leaves in general in a very holistic picture to make sure we weren't squeezing the balloon on one end and that it wasn't coming out on the other. So what you'll see here is about a 27% reduction on the short-term disability side in terms of duration. We all know that drives cost. The cost reduction in discrete dollars was 25%. We did put in day one benefits eligibility, which actually increased the number of people who were eligible and kind of going through this process. So that on its own sounds good, but did we push people to LTD? The good news is the answer was no, we didn't. What we found is we had a huge reduction in LTD claims. We're talking 30% per year. What we did realize, and you can kind of see it here, there was a 40% increase in cost, but it was cost per claimant. And as we unpacked that, we realized our overall cost went down significantly, but the people that represented those claims were the more severe cases, the more catastrophic people who should be on long-term disability. We're talking cancer, we're talking about those things where you really do need to be out. As we looked at workers' compensation, $5 million reduction in incurred year over year looking at that, 37% reduction in durations, which is the time that you're out of work. So again, from a productivity standpoint, you got cost, you got the claim, but you also have the productivity piece. Strong customer-focused dialogue with those individuals. And then finally, on the leaves side, we saw not a whole lot of tremendous movement. There wasn't anything up. If anything, it was down. And I'll let Dr. Bartlett talk a little bit about that in a kind of a three-year view of those claims.
Right, so you can see the trends where they're showing improvement year over year. In the FMLA bucket, I think the 2011 year would represent when most of the program was self-administered, and it appears that we were counting things a little different from when we took it over to when they did it themselves. So I'm not sure we had that dramatic of a decrease, but it's just a way that we each measure. But great results nonetheless.
Right. So
this enables us just a quick snapshot to show you how we look for alerts and patterns in leave. And so the system enables us to identify trends. And when I talked earlier about the employee-centric approach, when you're trying to get employees to work on Black Friday and you see that over the past 5 years they have not showed up on Thursday or on late Thursday, Friday, Saturday, Sunday of that year, then you know that you have to have more people coming in to work in the retail market. Also, if they're a weekend, traditionally working weekends in retail, and suddenly they're taking their time off on the weekend. So this enables them to really look at employees for the trends and identify those trends a little sooner.
all right, so reflecting back, and I think we're going to go to a turbo mode here so that we can cover this and then open it up for questions. But reflecting back, some of the keys to success where you can design the best thing in the world, but if you don't have the buy-in from the business and leadership and individuals who are partaking in it, you're not going anywhere. So we had cross-functional teams representing the business on the front end of these engagements to make sure they bought in and understood. We added a lot of enhancements at no additional cost, so it's pretty easy to make a business case where it's cost neutral, and then there's savings downstream. So essentially, we reallocated dollars that were spent in areas that weren't being valued to spending it and investing in these types of programs. So net-net, management would look at it and say, so you're telling me there's no cost change, you're not asking for more money, but you're going to give me money back later? Yes. So obviously that's powerful, but you also have to provide all the right tools and resources for people. If you don't, it's not happening. And even if you do provide it, it's no guarantee it will happen. We also clearly communicated the reason for change. People have a real issue getting on board if they don't know why they're doing something. And they will create their own reason why the company is doing it. So very, very important that people understand that. So obviously the accomplishments were on a compliance front, a health front, and a productivity front, but we have some kind of next phase items, and it was addressed a little bit earlier in terms of stress, but I'll let Dr. Bartlett talk a little bit more about it.
So when you think about stress, no matter if you're financially stable, very wealthy, or very impoverished, you think about stress, finances can cause you stress. So if the stock market dips 100 points, and even if you're a millionaire, you maybe are a little stressed. The other end of that spectrum is if you can't feed your family, or you're having trouble paying your car payment or your house payment. So stress really does cause unhealthy behaviors. It leads us to smoking and eating unhealthy foods and drinking or doing drugs. And there's a lot of studies and research to support the stress and the financial link. According to the University of Washington, we also see that stress and the financial stresses can lead to what? Stomach upset, ulcers, heart disease, psychiatric problems, depression, anxiety. So it is really important to understand that financial stress is linked to disease. And I think that leads to the next slide where Matt talks about his next step.
So we have to tie this all together. I think it was very well hit in the prior session to say, how does this all fit together? Well, biggest driver of healthcare cost is disease. Biggest cause of disease is stress or lifestyle. The biggest cause of stress and lifestyle are finances, okay? So there is that link. How do we help today? We're not doing enough. We have rebalancing 401k plans. We allow people who absolutely need it to get access to those funds, which creates a short-term solution and a longer-term problem. We offer free financial counseling for those who might not normally be able to afford it. We have all of the online tools and resources available, but we realize if we're truly going to complement physical wellness, we have to launch a more broad financial wellness and look at it as a total wellness for the individual.
Just curious, how many companies here are considering or have financial wellness programs by a show of hands? Quite a few. Or you're contemplating it? Okay, good.
And the market's really developing for this because there's a spectrum of, there's budget, people who can't save or they get confused because they can't make rent at the end of the month, so saving is not even a consideration for them, all the way to executives in your organization who have dedicated planners. So we have to provide kind of that whole spectrum to make those tools available to the right people. So there's a lot of work left to be done. I won't talk about the ACA. Everyone discussed that one pretty good this morning about how that's going to impact everything that we do. We know that we need behavior change. We know we need to continue to get at the root cause of things. We know that we need to be able to look at things more holistically and get that data to become information. We know that financial wellness and physical wellness and occupational and non-occupational disciplines need to all come together and look at it as kind of one holistic thing. And then once we kind of get that lens, we got to continuously improve everything to combat some of the changes that are out there. Obviously, we're not, as a country, moving in the right direction in terms of weight or diabetes. I think there was a gentleman earlier who was making that point pretty clear that we got a big problem here. And if we don't start working on it, we're only going to get in worse shape. So looking into the crystal ball, it's pretty simple. We want to bring it all together. We want to build on the successes that we've had and the learnings that we've had. We want to create some dashboards so that we can measure that and gain some credibility with our leaders and employers to continue to do these types of initiatives, and then look at things holistically. We want to make sure that if we can't prevent these things from happening, we get a lot further upstream in trying to address them.
So at this point, does anyone have any questions?
Yeah, Ted Thomas from the Ohio State University. My question is, moving to a consumer-driven health plan, was there any concern with gaps in care? So you said you had a population that were lower income, that they may not go to the doctor to care for their diabetes, and then 4 or 5 years down the road, you get a big chronic claim. Was there a concern with that population?
There was absolutely a concern, because if we're simply lowering costs and having a bunch of ticking time bombs waiting to hit us in 5 years, that's not going to solve the problem. So we had some pretty extensive conversations about how to combat that. Some of it is through adopting things like free preventive care, free access for those who have diabetes, for example, since you used that one, to tests to be able to manage their condition a little bit better, counseling services available for that. So we put all of those things out there. It was a real concern, and it's still a real concern that we monitor every day to make sure that people are not simply deciding not to engage in healthcare because of the cost, but providing as many of those things that drive some of these conditions at no cost or low cost. For example, if you are hypertensive, we would provide your medication at $5, because we know that's really critical that you're compliant. So we do really look at it very carefully. We still have concerns, but it's just something we're going to have to continue to combat and monitor to make sure that it's not a trend across kind of our organization and others. Because let's be honest, your employees could become my employees tomorrow and vice versa. So if we're not addressing this holistically, then we're just swapping time bombs.
And I think plus that required disease management participation would help with that. Any other questions, comments? Okay, thank you for your time today.
Thank you.